Hello, everyone. Thank you for joining today's webinar. Today, we're lucky enough to have representatives speak to us today about the connection of viral hepatitis and the opioid crisis, including the increase of incidence among people who inject drugs and how the CDC is addressing this epidemic. We'll hear from Dr. Carolyn Wester, who is the director for the CDC's Division of Viral Hepatitis. Prior to joining DVH, Dr. Wester served as the medical director for the Department of Health in Tennessee, a position she held since 2008. During her tenure at TDH, Dr. Wester led the daily operations for the TDH section, which was tasked with the prevention and control of HIV, STDs, and viral hepatitis throughout Tennessee. We will also hear from Michelle Van Handel, the Associate Director for the Program and Performance Improvement Office. Michelle has expertise in analyzing, synthesizing, and interpreting national-level survey, census, surveillance, and program data to advance the efficiency, outcomes, and impact of prevention programs. And last but certainly not least, we will hear from Judith Leahy, who has been the Oregon Adult Viral Hepatitis Prevention Coordinator since 2009. In this position, she organizes the state's public health response to viral hepatitis, and she engages with state and local stakeholders to align and leverage programs to support hepatitis prevention, screening, and linkage to care activities. Through mostly collaborative efforts, she works to prevent new hepatitis A, B, and C infections, improves health outcomes for people with hepatitis, eliminates community and population health disparities, and decreases future medical costs in Oregon. Obviously, we have a great a panel here with a lot of expertise to tell us all about this topic. So first, I'll give the floor to Dr. Wester.
Great, thank you very much. I appreciate the opportunity to be with you this afternoon. For the next 10 minutes or so, I'll discuss the increasing incidence of viral hepatitis in general and specifically as it relates to people who inject drugs. Viral hepatitis, as you know, is a massive public health burden, with approximately 2.5 million people in the US infected with Hep C and nearly 900,000 people infected with Hep B. Not only are these numbers staggering in and of itself, but new infections are on the rise as well. Additionally, about half of the people living with Hep C and about 2/3 of the people living with Hep B haven't been diagnosed and remain unaware that they are infected, precluding them from accessing care and treatment, which can prevent advanced liver disease and even death. However, not all groups are affected equally, and as you'll see in the next few slides, rates of new viral hepatitis infections are increasing most dramatically among young adults with a history of injection drug use and living in rural areas. This slide illustrates the geographic correlation between opioids and the hepatitis C epidemic, one of the infectious consequences. In these 2016 maps, counties with darker shading represent higher rates. In the top left is a map of opioid prescribing rates, meaning the number of prescriptions written per person in that county. In the bottom left is a map of drug overdose rates, and in the bottom right is a map of new Hep C infections. In all three maps, you see that the areas of darker shading have pockets in the west, Appalachia, and the Northeast, representing areas that are hardest hit by these overlapping epidemics. While this slide highlights Hep C's relationship to the opioid epidemic, you'll see in the next few slides that all of the three major types of viral hepatitis in the US, Hep C, Hep B, and Hep A, are increasing among people who inject or use drugs. We'll start with Hep C, which is a blood-borne virus that is predominantly transmitted when an uninfected person comes into contact with infected body fluid, particularly blood, and most often by sharing injection drug equipment. Hep C can also be transmitted from mother to child and sexually, although less commonly. This graph illustrates the number of reported cases of new hepatitis C in the US each year from 2001 to 2016. You can see that the number of reported cases has dramatically increased since 2010. This slide breaks down the rates of reported new Hep C cases into age groups over the same time period. And you can see that since 2010, the large increases have been driven by people aged 20 to 59, and particularly in the 20 to 39 year age group. This breaks it down a little bit further and provides a little bit more information about young adults or individuals less than or equal to 30 years of age living in 4 of the states hardest hit by both the opioid and hep C syndemic, specifically Kentucky, Tennessee, Virginia, and West Virginia. On the left, you see increasing rates of hepatitis C from 2006 to 2012 among these young adults. The rates are increasing both in urban areas represented by the dark blue bars, but even more markedly in rural areas shown by the light blue bars. On the right, you can see over the same period of time in the same population that the rates of admission for substance use treatment, the top dark blue line, were increasing as well. Given the rising rates of hepatitis C among reproductive age adults, it's not surprising that the number of babies being exposed to hepatitis C during pregnancy and delivery is increasing as well. This slide shows increasing rates of babies born to hep C infected women from 2011 to 2014 in the US, as represented by the red dash line, as well as in Kentucky, represented by the blue bars. If you look at just the blue bar for 2014, the rate is staggering. The data shows that 1 of 63 babies born in Kentucky in 2014 was exposed to hep C before or during birth. And we think the actual numbers are much higher, given that pregnant women are not currently routinely tested for hep C during pregnancy, and nearly half of people living with hep C are indeed unaware that they're infected. Since about 75% of newly infected individuals with hep C develop chronic or long-term infection, it's important to look at the prevalence of hepatitis C too, meaning the number of people living with hep C, regardless of whether they were recently or remotely infected. In this map, the states shaded in darker colors have higher estimated numbers of people living with hepatitis C infection. Overall estimated prevalence in this slide ranges from 0.45%, or about 1 in 200 people in a low burden state, to 2.34%, or about 1 out of every 40 residents being infected with hepatitis C. As we saw in previous maps, some of the highest rates are in the West, Appalachia, and other states heavily affected by the opioid crisis. Not surprisingly, the rates of hepatitis C infection among clients in substance use disorder clinics, treatment facilities, are even higher. The far right column, which represents hepatitis C RNA, which indicates current infection, indicates that about a third of the people in substance use disorder clinics are actively infected with hepatitis C. And rates among people with specifically a history of injection drug use, which is not shown here, are even higher and estimated to be about 40 to 70%. This slide looks at the rates of hepatitis C infection among inmates in correctional facilities in several states. While the rates are slightly lower than the prior slide, about 5 to 20% of inmates in these facilities were living with active hep C infection. And it's important to realize that neither this slide nor the prior slide included some of the Appalachian states with the highest rates of hepatitis C. I'm now going to shift to hepatitis B, another bloodborne virus that, like hepatitis C, can be transmitted when an uninfected person comes into the contact with infected body fluid, like blood or sexual fluids, including sharing injection drug equipment. Hepatitis B can be transmitted sexually and from mother to child as well, even more so than hepatitis C. But the good news is that hepatitis B is vaccine preventable. This slide shows the number of reported new hepatitis B infections in the US from 2001 to 2016. We see dramatic decreases in cases from 2001 to 2010. However, the line has remained relatively flat or even had an uptick since 2010. You may ask why. The early decreases are related to the availability and recommendations for hepatitis B vaccine, specifically among children as well as at-risk adults. You can see that routine childhood vaccine for hepatitis B has been recommended in the US since 1991. So that means that most individuals less than 28 years of age at this point have now been vaccinated. Hepatitis B vaccination is also recommended for individuals who are at risk of acquiring hepatitis B regardless of age, including people who share injection drug equipment or are incarcerated. However, while hepatitis B vaccine coverage rates are excellent among children, there are a lot of at-risk adults who remain unvaccinated. This slide shows that increasing rates of new hepatitis B infections are in the adult groups age 30 to 59-year-old, which is similar to what we saw for new hep C infections, except for that this is even a little older, about a decade older, due to the protective effect of childhood hep B vaccination practices introduced in '91. Here we see something that we saw very similar in a prior hep C slide, specifically that rates of new hepatitis B infection are even higher in rural areas, as represented by the red bars, than metropolitan areas, as represented in the blue bars. Similarly, on this slide on the left, you can see that the rates of hepatitis B infection are highest in Appalachian states, represented by the dark blue line on the left, as well as on the map on the right, represented by dark blue shading. Oh, I'm sorry, I'm a slide behind, I apologize. And we see the correlation between injection drug use and new hep B infection is illustrated here. Among people with newly reported infections, although risk factor ascertainment was only attained in about 22% of individuals, of the people reporting risk, about a third reported a history of injection drug use. This slide just reiterates a point that I made earlier. Specifically, only a small fraction of people living with hepatitis B and hepatitis C are actually aware that they're infected. This speaks to the need to increasing testing among adults at risk of infection. I'll wrap up with hepatitis A briefly. Hepatitis A is different from C and B in that it is transmitted from person to person through a fecal-oral route, meaning that it can be transmitted when someone fails to wash their hands after using the bathroom and then touching something that may come in contact with another person's mouth, a body part, drug equipment, food, etc. Similar to hepatitis B, hepatitis A can also be prevented with a vaccination. This slide shows that the number of reported hepatitis A cases in the US dramatically decreased from 2001 to 2016 and then held steady for a couple of years. However, we've seen an uptick since 2016. Like hepatitis B, the decreases initially were predominantly a result of increased vaccination, which has been recommended routinely for all children in all states since 2006. And is also recommended among adults with risk factors, including people who use drugs. And similar to what we saw for both hepatitis C and B, the recent increases over the last several years have been driven primarily by increased rates among adults. The increases in Hep A since 2016 represent a shift in the epidemiology of Hep A. Specifically, past outbreaks were associated with asymptomatic children. However, with a large population of at-risk yet unvaccinated adults, we're seeing increased rates in these populations. Additionally, we're seeing higher hospitalization and death rates among infected adults. This map, which is similar in case distribution to the maps we saw earlier in this presentation, illustrate the areas hardest hit by the recent multi-state Hep A outbreaks. Since 2016, about half of the states have been affected, with over 18,000 cases reported, and with a hospitalization rate of approximately 60% and a death rate of 1%. Reported cases have primarily affected people who use drugs and people experiencing homelessness. To summarize, rates of new hepatitis C and B infection are high and on the rise, particularly among young adults residing in rural areas affected by the opioid epidemic. The US is experiencing multi-state hepatitis A outbreaks predominantly among young adults who use drugs or are experiencing homelessness. Vaccination is the cornerstone of prevention against hepatitis B and hepatitis A. and about half of people living with hepatitis C and about 2/3 of people living with hepatitis B are unaware of their infection. I want to thank you very much for your attention and the opportunity to present.
Thank you, Dr. Wester. Okay, we'll now give control to Michelle Van Handel.
Great. Hello, everyone, and thank you for the opportunity to present on CDC's vulnerability assessment to identify areas at risk for HIV or hepatitis C outbreaks related to unstable injection drug use, as well as CDC's activities to address the infectious disease consequences of the opioid epidemic. Okay. All right, great. Today I'll just be giving a bit of a background related to the outbreak that occurred in 2015 and 16 in Scott County, Indiana, and what led us to conduct the 2016 National Vulnerability Assessment for HIV, AIDS, and HCV, and then wrap up with some activities that we're working on to address the infectious disease consequences of the opioid epidemic. In early 2015, 11 new HIV infections were diagnosed in Scott County. In comparison, there had been less than one new HIV diagnosis annually in the past 10 years in the county. There have now been 235 new HIV diagnoses associated with the outbreak, and the impact of injection drug use on the community was apparent, with more than 90% of those diagnosed with HIV also co-infected with hepatitis C virus. The initial response started like many HIV investigations with case finding and partner testing. The local and state public health authorities quickly realized this was not a normal investigation and implemented an incident command system like you might do for a natural disaster in order to be able to respond to this outbreak. The response required a large and intensive collaboration of local, state, and federal public health resources in partnership with the community. During the response, they were able to establish the extent of the HIV infections and institute prevention and control measures. These HIV transmissions were occurring in a dense network of people who inject drugs, specifically the opioid analgesic oxymorphone. It is also important to note that this community was dealing with many health and social issues in which the county ranked 92nd among Indiana's 92 counties. The county had the lowest life expectancy in the state, 9% were unemployed, 19% were living below the federal poverty level, and 21% did not have a high school degree, and many were uninsured. As Dr. Wester has already shown, while this outbreak was occurring nationally, the infectious complications of the opioid crisis were most evident with increases in acute hepatitis C, and acute hepatitis C cases have continued to soar. As well, there continues to be a geographic correlation between overdose deaths and new HCV infections, with many of the same areas on these two maps shown in red experiencing both of these negative outcomes. Furthermore, the increases in HCV infections have been in areas with historically low rates of HIV infection. An MMWR in 2015 showed that incidence in non-urban areas was more than twice urban areas, increasing at a faster rate. Previously, persons infected by injection drugs were more often living in urban areas of minority race or ethnicity and mostly male. Most recently, outbreaks of HCV and evidence of injection drug use are increasing among persons of white race ethnicity in rural areas, with nearly as many women as men affected. Given the transition in the demographics and the expansion of acute hepatitis C cases, as well as other indicators of non-sterile injection drug use, we sought to identify counties in the U.S. that were potentially vulnerable to rapid dissemination of HIV or HCV among people who inject drugs if the virus is introduced. This information can be used to increase awareness for potential events similar to that which occurred in Scott County, Indiana, and can help state and local health departments assess their risk and intervene quickly to prevent a future outbreak. It is important to emphasize that this analysis focused on vulnerability based on injection drug use, and that all people living in a county identified as vulnerable are not necessarily at risk, but rather the data indicate there may be a population of people who inject drugs who are vulnerable. We used a multi-step approach to conduct this assessment, aiming to answer two key questions: which variables are associated with acute hep C infection, and which counties have the highest vulnerability to an HIV or HCV outbreak. This approach is similar to the development of predictive composite indicators such as the Framingham score, where multiple clinical variables are used to predict risk for the outcome of a heart attack. In this case, we identified which county-level variables available in national data sets were predictive of acute hepatitis C infection at the county level versus using characteristics at the individual level. We then calculated a composite index score, which we refer to as the vulnerability score. We first identified the most parsimonious set of variables that would predict unstable injection drug use. Unfortunately, this outcome is not measured uniformly at the county level in the United States, so we needed to choose a proxy measure, and we chose acute hepatitis C infection cases because HCV is highly transmissible through unstable injection drug use, and it is the strongest risk factor for hepatitis C. Second, the acute phase of HCV infection occurs very close in time to the injection event, and so is transitory, so that the two events are likely linked closely in both time and space. And lastly, because national surveillance for acute hepatitis C infections exists through the National Notifiable Disease Surveillance System. In order to do this analysis nationally, we required variables included in the model meet 4 criteria. They must have been known or plausibly associated with injection drug use, available nationally at the county level, be recent, which at the time was 2012 or later, and complete with at least 90% of U.S. counties with valid values. We identified 15 indicators that met these criteria, and through a multivariable, multi-level Poisson regression model, identified 6 variables shown on this slide that were significantly associated with acute hepatitis C at the county level. Within this step, please note that we excluded data from 8 states and DC because these jurisdictions did not report acute hepatitis C cases at the time, but when we calculate the scores, we're able to do that for all of the states and counties in the US. So the standardized relative risks presented in this table allow for easier comparison across the indicators to better understand the relative contribution in predicting acute HCV incidence. The 6 indicators in order of strength of association were the percent of the population of white, non-Hispanic race ethnicity, drug overdose deaths, per capita income, unemployment, prescription opioid sales, and buprenorphine prescribing potential by waiver. Once we had a parsimonious set of predictor variables from the Poisson regression model, we calculated the vulnerability score and then rank ordered each U.S. county by score to identify those with the greatest potential vulnerability. Using this multi-step approach allowed us to calculate a score for each U.S. county using the indicator data and not the counties for which we had acute hepatitis C data. We identified 220 counties shown on this map in green as most vulnerable to rapid dissemination of HIV and HCV infections among persons who inject drugs. These counties are located in 26 states, and as you can see, they are largely focused in the Appalachian region, with other clusters in the Northeast, the Ozarks, and the northern part of Michigan. We also wanted to better understand the rate of HIV in these areas, as we knew that there had been transition of increases in hepatitis C in areas that had not been previously as affected by HIV. So we estimated the rate of people living with diagnosed infection in and around each county. And we did this by calculating a weighted average rate of people living with diagnosed HIV in the county, as well as proportionally just looking at 20-mile borders around each of the counties. The estimated HIV proximity ranged from 0.9 to 37.6 per 10,000 population. And with one exception, the estimated HIV proximity rate for all vulnerable counties was lower than the national rate of 29.3. Following the publication of this analysis, states started building on this approach and using it to drive program decision-making. In 2018, Tennessee published their state-led vulnerability assessment, adding local variables, specifically opioid and heroin overdoses, as well as morphine milligram equivalent prescribing from the state's prescription drug monitoring program. By using local and more recent data, Tennessee was able to identify a different region than what had been identified in the national assessment, the southwest part of the state. and they also had the additional local context to help interpret these findings. Kentucky has leveraged the national assessment to inform where to implement syringe services programs. While not in exact alignment, you can see that the counties identified in the national assessment in green with an SSP, the red stars, have increased substantially from 2016 to 2018. In both states, local context and an understanding of prevention and intervention needs has been combined with assessment results to inform prevention priorities for the state, particularly for persons who inject drugs. State-led assessments also have the advantage of access to local data, access to more timely data, and the opportunity to more routinely engage with stakeholders to build buy-in for the assessment, dissemination of results, and use of the results for program planning. I'll talk more about this in just a moment, but these are some of the reasons why one of our activities to address the infectious disease consequences of the opioid crisis is to support each state to conduct its own vulnerability assessment to provide a more sensitive portrait of local needs that allows more timely and rapid scale-up of targeted services. CDC has a number of activities to address the infectious disease consequences of the opioid epidemic, so that we are all working together to prevent harmful opioid use, prevent viral hepatitis, and improve treatment for substance use disorder and infectious diseases. First, we need to know where to focus on. We are a nation at risk, and as you can see in this map, CDC has identified that 46 states, DC, and Puerto Rico have documented areas experiencing or at risk for increases of HCV or HIV. The pink shows the 220 counties that were identified in the national assessment as most at risk, and then the green shows the states that have submitted a request to CDC for determination of need for implementing syringe services programs or SSPs. Since 2016, Congress has allowed federal resources to be used for the implementation of SSPs, minus any injection equipment, as long as the jurisdiction has a concurrence from CDC that it has a need. The white simply means that the state has not yet requested this determination from CDC, which may be due to a lack of a policy-enabling environment in the state to operate SSPs legally. We also have several resource pages with material that can be used and modified by health departments or other organizations for local purposes. For example, this fact sheet is a summary of evidence of syringe services effectiveness, and this one provides basic information about HIV and injection drug use. We also provide guidance documents and, of course, early planning support for preventing and responding to HIV and HCV outbreaks among networks of people who inject drugs. This type of planning is key, and in order to assist in that process, CDC developed a guidance document for local health departments that includes, among other, strategies to detect and investigate outbreaks, example response plans, and planning tools, as well as information on requesting assistance from CDC. The document also stresses the importance of establishing strong relationships with local partners early, including law enforcement. And as I mentioned, we are currently supporting health departments to develop and disseminate jurisdiction-level vulnerability assessments that identify sub-regional areas such as county or census tracts at high risk for opioid overdoses and bloodborne infections associated with non-sterile injection drug use. Findings from the vulnerability assessments will be used to identify prevention and intervention gaps through an analysis, develop and initiate multi-sector plan to address these gaps, as well as engaging stakeholders throughout the process to provide input and support development and use of the assessment findings. In parallel, for this project, we are also supporting a technical assistance provider to provide expertise on data sources and data management, to conduct webinars and convene small groups for in-depth learning opportunities to develop the assessment. And this includes peer groups that were grouped based on jurisdictions with similar data collection or methods, as well as focusing on statistical and data visualization approaches in order to develop the assessment and produce high-quality products for dissemination. And lastly, as needed, we're providing ad hoc technical assistance in order to help states complete and disseminate their assessments. We also recognize there is a great need to accelerate our impact in harm reduction programs. It is critical that there is a local effort to mobilize a multi-sector community response that includes healthcare, public health, and law enforcement. A common harm reduction program is a syringe services program, or SSP. SSPs prevent infections and do not increase drug use or crime. Studies have shown that there is a 58% reduction in incidence of HIV and 52% in HCV, with greater effects when they are combined with substance use treatment. SSPs also prevent overdoses and are able to link patients to treatment. CDC is working to ensure that where SSPs are implemented, they are as comprehensive as possible. For instance, comprehensive syringe services programs would include referrals for substance use treatment, access to naloxone, viral hepatitis, and HIV testing and treatment, sterile equipment, and vaccinations. Together, these analyses, support, and activities help us use data to identify communities and people experiencing poor outcomes at risk for worsening outcomes, so that we can use this information to drive prevention and intervention plans nationally, as well as support organizations locally. Thank you so much for your time.
Thanks so much, Michelle. Okay, we'll now give the floor to Judith Leahy.
Hi, thank you. I'm going to advance. Thank you for the opportunity to speak with you today. My name is Judith Leahy. I work with the Acute and Communicable Disease Program within the Oregon Public Health Division, and my plan is to share with you how we came to develop our Oregon syndemic model, the ways we are using the model to support a more unified public health response to substance use, overdose, and infectious diseases related to drug use. My hope is that you find this information useful for your efforts to engage with community members and to connect federal, state, and foundation funding, government and non-government agencies, and state and local agencies and programs to address the health disparities that exist for people who use drugs and to support community resilience and response. The Oregon syndemic model was developed for use by the Oregon's HIV, hepatitis, and opioid prevention and engagement study, which I'm going to call from now forward ORHOPE. ORHOPE is one of the 8 grantees of the NIH, CDC, SAMHSA, and Appalachian Regional Commission, or ARC, partnership to explore and develop an integrated rural community response model that can be implemented by public health systems in rural communities. This is a G3 exploratory and developmentally phased award, so it has 2 parts. The ORHOPE study has 2 aims, which are to better understand how rural communities are affected by substance use, overdose, injection drug use, and infections related to substance use, including HIV, hepatitis C, and syphilis, and to develop, conduct, and evaluate a rural response effort that addresses these issues together through screening, linkage to care, and rural provider training and response. So in other words, our plan is to learn about rural drug use and related infections, and then development, implement, and evaluate an intervention that can be sustained and used by public health in rural areas after the study is over. My apologies. Okay. As you know, injection drug use has led to increases in and outbreaks of hepatitis C, HIV, syphilis, and other injection-related infections in communities, including rural communities throughout the United States. So in order to effectively respond, we needed to improve our understanding of the context of substance use in rural areas, and then a unified response that we could successfully implement. The Oregon HOPE study has piloted in 2 counties, and if we're successful with our submitted UGH grant application, our project will expand to actually 9 additional counties. We've added 1. To give you a point of reference for the size of our pilot counties, Douglas County is roughly the size of the state of Connecticut. Whoops, and this, I apologize for the mistake in the slide. So the ORHOPE project has, The ORHOPE study it's a 3-level intervention that includes a structural and community level, a provider level, and a patient level. So the development and use of the syndemic model is part of our structural and community level interventions, and it's what I'm going to mostly focus on. So in ORHOPE, we use our syndemic model to frame aspects of how we're doing our data collection and to leverage existing community action teams, which previous were focused on opioid overdose and are currently pivoting to include opioids and other drugs. And we're hoping to increase and integrate an awareness of infectious diseases inside of these community organized groups. So as we developed our model, we sought input and feedback from colleagues across the Oregon Health Authority. And then when we felt we had a working model, we presented it to the leadership within our public health division, to including other health programs, our injury and violence prevention program, our health promotion and chronic disease prevention program, our immunization program, maternal and child health, and our HIV, STD, TB program. We also, in developing the model, consulted other divisions inside of the Oregon Health Authority, including our Health Systems Division, which is where our Medicaid program is, and our Addiction and Recovery Services. We also consulted with the Oregon Department of Corrections. So we've disseminated our model to our state leaders and have presented at places that have included the Opioid Policy Academy, our Oregon Epidemiologist Conference, where our county and all of our health officers attend, the Oregon Conference on Opioid and Other Drugs, which is kind of the behavioral counterpart to our EPI conference, nationally at the NASTAD Technical Assistance Meeting and the National HIV/AIDS Meeting, and we're really excited to share it here with you now. Before we move on to that, I did want to show you, even though I'm not going to speak in detail about it, the other two levels of our intervention, because I think that they're important to consider, because as we kind of talk and approach this syndemic issue, we're going to need to approach it from multiple levels using syndemic thinking. So at our provider level, what we're doing is, in terms of data collection, is we did a scan and we looked at the number of buprenorphine prescribers we had in our state, the number of hepatitis C treatment prescribers, and we developed and implemented and expanded our buprenorphine waiver training, our addiction medicine ECHO, our hepatitis C ECHO, and we worked with our AIDS Education Training Center to develop what we're calling the HOPE curriculum, which is an integrated CME curriculum that addresses opioid use disorder, hepatitis C, and HIV. In the map that you see on this slide to the right, the darker areas are where we kind of mapped out where are concentrated areas of adults living with chronic hepatitis C. So in some of our counties, we have at least 1 in 40 adults with hepatitis C. And as you can see, particularly down in where we're working on our HOPE counties, in some of these counties, we have 1 to 0 people who had prescribed a medication to treat hepatitis C. So one of our interventions at the provider level was really to work on increasing awareness and capacity to provide care to people. And at our patient level, we have conducted risk assessments on surveys with people who use drugs, including qualitative interviews, to get a better understanding of the context of initiation and drug use and experiences with medical and substance use programs. The interventions that we are working on is we are working to expand syringe exchange and mobile outreach. And then we also are using peer support specialists. They're a specific type of peer in our Medicaid system that reach out into active networks of people who are injecting drugs and provide hepatitis C and HIV testing. They do harm reduction work, including distributing naloxone, fentanyl test strips, and syringes. And they provide linkage to care, treatment, and other services for people who, in general, are completely disengaged from care. So these are people that our peers are reaching out to, starting from the syringe exchange and hoping to get them linked into that. So I wanted to talk a little bit about what a syndemic is before I show you our syndemic model. So the word syndemic refers to multiple epidemics that interact with each other. The beginning of this word, syn, S-Y-N, comes from the Greek and means with or together. So what we're talking about are multiple epidemics that occur with one another. It does not refer to comorbidity or co-infection. Individual epidemics are not isolated or siloed from one another in a syndemic model, and they interact at the level of cause, consequence, or how we might respond or deal with them. So syndemics arise from conditions of health inequity and harmful social conditions. So an effective response to a syndemic includes understanding and addressing those root causes, core issues, and the links between them. The approach of addressing root causes, links, and core issues aligns a syndemic response within a health equity and social determinant of health framework and strategies. Oops, my apologies. I was reading. I didn't realize this was connected. So using a syndemic lens allows us to identify effective partners and allies and articulate our relationships. A syndemic lens also aids effective policy analysis and planning and program planning and evaluation. Lastly, a syndemic approach supports collaboration across programs, systems, and levels, including individual, community, and policy interventions. So the model that I'm going to show you describes the relationships that we've seen between substance use, overdose, infectious diseases, and other drug-related issues. So the lines in the model mean that the input issue or condition is caused or related to what it's linked to. And then we define substance misuse as the use of substances for a purpose not consistent with legal or medication guidelines. So the model provides us a framework with how to communicate how issues, conditions, and outcomes are linked, facilitate collaborations across health and social justice systems, and support effectual policy analysis and coordinated actions, and implement integrated interventions and coordinated surveillance and monitoring of shared indicators. So in our model, it really is centered on substance use, misuse, and disordered use. And you can see we also included alcohol, prescription drugs, and over-the-counter drugs, as well as illegal drugs with misuse potential. You see the three of those linking to conditions that for us allow us to collaborate with or support our collaboration with maternal and child health and nutrition programs such as WIC. We also have overdose morbidity and mortality, and suicide is actually the leading cause of people with substance use disorders. So reaching out to our suicide prevention partners and talking to them about our model and how we can support and leverage our work together. One of the important things also to note in the model is that one of the things that makes overdose such a challenging challenging issue to work on is that people can overdose from taking prescription drugs as they are prescribed, as well as from misuse and disordered use of drugs. So here you also have very similar in terms of substance use leading to unintentional sexually transmitted infections. And then you have the transition to injection drug use and related to injection drug use infections. And then at the end is the small print, but I want to just highlight that even though it's small, it is not a small issue. The root causes and social economic issues that underlie our model include adverse childhood experiences and toxic stress that affect the access to and availability of resources to prevent, respond, and recover for communities. They influence the experience of risk and protective factors, and they shape individual level physical and emotional health, resilience, and risk behaviors. So the syndemic approach that we used led us to do a state and local policy scan, and we framed it around these 5 questions. So what were the strengths in our policy responses so far to these issues as a syndemic? What progress have we made? What are the gaps? And what policy and issues need further investigation? And then how we could work together and influence conditions outlined in our syndemic model with a policy response. So the next thing we did, as I mentioned earlier, we wanted to support our community and community action teams to begin to address these issues in a syndemic framework. So while the syndemic model illustrates the relationship, our community action teams are tasked to come up with public health-based responses. So looking to the literature, I came across the conceptual framework from the Association of State and Territorial Health Officers, and we modified it to include our syndemic approach. So here you see on the left we made a list of key strategies. And looking at the model, we have policy and environmental and social determinants. We have the diagnosis and treatment of conditions and infections. And we have preventing acute and life-threatening outcomes. So when you look at those three levels of response, the level at the base is focusing more on our long-term community approaches, and the top is focusing on immediate and individual, usually individual level approaches. And I think in terms of responding at the community level, it's really about working with community action teams to consider all three and not to focus just on one or the other, but to really take into consideration it's a marathon, not necessarily a sprint, and it's really important to address the life-threatening outcomes that communities are experiencing. So in our model, at the kind of base, some of the examples here are things like insurance coverage and parity, and laws and rules and policies that would support health, diagnosing and treating substance use disorder, alcohol use disorder, infectious diseases, and injection-related infections. And then also preventing overdose and suicide, infections, and exposure of unborn infants to drugs, alcohol, syphilis, hepatitis B, C, and HIV. On the right side, what we've done is we've compiled a list of interventions that are either promising or evidence-based, and for the different levels. And we put this information along with community level data on HIV, hepatitis C, syphilis, opioids, for our state, methamphetamine, morbidity and mortality, and then hospital discharge data related to injection drug use. And we've made fact sheets, and we've been presenting this data to our local partners. So the aim is really of sharing and presenting this data is to increase discussion and awareness that these challenges are linked and that local responses can possibly be coordinated and leveraged, to build buy-in for programs to address root causes and address common consequences, and to support different stakeholders to ground their responses in promising and evidence-based interventions across our state. So I quickly wanted to thank my colleagues and those who may be listening from OHA who have both embraced and supported our syndemic model and approach, our community partners who provided input and guidance to our efforts, and then the ORHOPE study team. We are a group of diverse partners, and we work across these different levels to understand this work, and also the actual collaborative funding partnership of NIH, CDC, SAMHSA, and ARC that made our project possible. And thank you.
Thank you so much, Judith. Okay, so now we do have a few minutes for questions. If anybody has a question, please put it in the question box to your right, and I will read them out loud for the speakers. I guess the information was that good. There are no questions. If you do have any questions later, please email me and I will get those to the speakers.
I was going to say, this is Jude from Oregon again. I have some people from our team in the room with me, and one of them suggested that we talk about the fact that through this project, we've been able to increase syringe service programs in multiple counties in our state. And also we are completing a syringe service implementation guide that will be available in our state, but also will be posted to our website.
Thank you. Okay. I will give the floor to Tom now. Someone did ask a question. Will this presentation be available later for later viewing? Yes, it will. We've recorded it, and we will share that with everyone early next week. Well, it seems that Tom has some technical difficulties, maybe. So with that, I guess we will go ahead and end this webinar, but I do want to say thank you so much to Dr. Wester, to Michelle and Judith for taking the time to speak to our staff about this such important topic. It was great content.
Thank you.
Thank you.
Thank you.
Thanks, everybody.